Thanks, Jamie and Shannon and everyone from EveryLife, and certainly all the members of the caucus and the staffers here today. I am going to talk about improving access to care and treatments through the lens of medical foods, medical nutrition. We referenced my titles. I work for Flock Health, which serves those with inborn errors of protein metabolism. But before I did that work, I was mom to Isabel. And you see her here. She's going to be 13 next month. I took this picture about 5 seconds before I picked up the phone and listened to my voicemail saying that she'd been flagged on newborn screening for PKU. And so this is my pre-advocacy picture, and thus begun my long journey for advocacy in medical nutrition. You can't tell from this photo, but my hair was brown then. And so the first question everyone asks is, well, what is medical nutrition? I don't get it. And that's fair. So medical nutrition is not groceries. It is not, low protein. It is not gluten-free bread. It is not dairy-free milk. It is not vegetables. These are specially designed medical products defined under the Orphan Drug Act as medically required nutrition. And that makes it a little hard to get reimbursement on them because they're in this special category. But for a set of conditions, which I'll talk about, they're the baseline of care and often the only treatment for these conditions, including inborn errors of metabolism. That first month, day 7, when we started Izzy on formula, we were looking at a cost of $1,800 a month, and for adults that can exceed $5,000 a month. That's lifelong. Medical foods, like that low-protein pasta you see there, they're often 5 to 10 times the cost of standard groceries, and they're only available by special order. So that is the practical definition of medical nutrition. The statutory definition is very strict, and that's an important thing to understand about the bill I'm going to talk about. It's furnished on order of a physician. It's specially formulated and processed for oral intake or tube feeding. It's for people who can't ingest, digest, absorb, or metabolize ordinary food. They need this to survive. And it's used under medical care and for a patient undergoing active medical care. So it's not a sort of set it and forget it. The population that the bill I'm talking about, which is the Access to Medical Foods and Formulas Access Act, the population it serves are 2 different groups. One is inherited metabolic disorders on the RUSP, so those caught on newborn screening. The reason they're on newborn screening is because they are acute, they need immediate treatment, and we have a treatment, and that treatment is medical nutrition. So we're looking at amino acid disorders, and I'm not going to read the whole list there, but all of those are on the RUSP for a reason. They're often very small patient communities. PKU is the biggest one of those. And there's about 250, 275 babies born a year with PKU. They are using the treatments lifelong. This bill also covers those with digestive and GI conditions. Those include short bowel syndrome or food protein allergies, or more common conditions like Crohn's and colitis. It's important to know that while these are relatively larger patient communities, there's usually temporary or intermittent use. It might be to get someone into a healthy state or a healthy weight where they can accept a pharmacologic or biologic treatment, or even to get a baby to a certain weight where they can have a life-saving liver transplant, for example. This beautiful quilt, this patchwork is provided by NORD. Overall, they give our country a C for medical foods coverage. And while it is lovely in all these pretty colors, I would argue the reality looks like this, because even those states that have coverage, that have state mandates for medical nutrition, insurers can deny coverage based on what condition you have. So PKU is written into the bill, but a lot of others aren't. Age, gender, insurance type, and delivery method. And in that case, I'm not talking FedEx, UPS, I'm talking about how it is consumed. A lot of insurers will only cover formulas if they're delivered via a G-tube. And so you're exposing an individual to surgery, ongoing maintenance, not to mention the cost, just to get approval of that formula. And people do it. They have to do it because they need these formulas and medical foods to survive. We also have people moving from state to state or not moving from state to state because they can't lose their coverage, getting divorced because then they qualify for different plans. It's really incredibly destabilizing to these really rare communities. So the Medical Foods and Formulas Access Act, 5684 in the House, 3304 in the Senate, provides a federal floor of coverage. It says we understand that these are required medical nutrition and our public health programs, fourth one, should cover it. This bill existed in many prior Congresses, at least 6 in my experience, but going back 20 and 30 years. The last few, it was known as the Medical Nutrition Equity Act, and it did cover private insurance at that time in that bill as well. This bill is different because it is just the public programs, but it does contain sense of Congress language that all health plans, including private health plans, should provide coverage of and access to medically necessary food, and that's defined as both those foods and formulas. There's nothing new here. Congress has already said yes to this. The 2016 Defense Reauthorization put this into law for military families in TRICARE. In 2023, a member of the PKU community advocated for the federal employee benefit plans to cover metabolic formula. It does not cover medical foods for that community, and again, that's just the IMDs. It doesn't cover GI. After the 2022 formula crisis, which hit the metabolic community incredibly hard, the Consolidated Appropriations Act recognized these medical foods and formulas as critical foods that we needed to protect as a country. And so this bill, the Medical Foods and Formula Access Act, just takes all of that and extends it to the rest of the population on public health care. We're incredibly grateful and lucky for bipartisan bicameral support through several iterations of this bill. You can see the committee referrals there. Obviously, these are the bill leads and original co-sponsors, but we do have a significant list in both the House and Senate. The community is behind this bill. We don't have 250 organizations, but we've got at least 50. And that's ranging from the American Academy of Pediatrics, NASFGAN, who has done a ton of work on this bill, Children's National here in DC, and then a bunch of disease-specific organizations who see this as the best solution for care for their communities. There is, so the ask here is to take back to your offices, talk with your staff about the Medical Foods and Formulas Access Act. You can reach out to the leads to sign on for co-sponsorship. The QR code there goes to nutritionequity.org, which is the coalition website that represents all of those organizations supporting the bill. There are stories there, state by state, condition by condition, to really understand the impact, the personal impact of medical nutrition and the lack of it. So thank you for your time. I'm going to end where I began, with my daughter as an advocate. That was the beginning of my journey. This is her in Cory Booker's office. I don't know how much protein is in those business cards, but she ate them. In 2020, she advocated remotely from our backyard during COVID, and then 2 years ago, that's her pacing in front of the Reagan office building, working on her speech that she delivered during Rare Disease Week to her legislators. There's a little space there and the rest of the screen. I'm hoping I don't have to fill it with her coming back to ask for this bill to be passed again. So let's just build on the momentum. Thank you for your time. And I'm going to pass it off to Carolyn.
Thanks so much, Sarah. And so let's conclude with